What if the patient you're worried about is the one most at risk? In pediatrics, we're trained to look for red flags like low weight, faltering growth curves, and visible signs of malnutrition. But atypical anorexia challenges that instinct. These patients may sit comfortably on the growth chart or even above it, while experiencing the same dangerous behaviors and medical instability as those with classic anorexia. In this episode, we rethink what we've been taught to look for. We explore how atypical anorexia presents, why it's so often missed, and what it takes to recognize the warning signs hiding beneath the surface. This is Charting Pediatrics. To discuss this important topic, we are joined by Dr. Kimberly Sheffield. She's an eating disorders psychologist here at Children's Hospital Colorado, as well as the clinical director of the Pediatric Mental Health Institute Day Programs and the associate training director for psychology training. Kimberly, welcome back to the podcast.
Thanks for having me.
So, this is kind of something new. It's not something that I learned in my own residency training. Tell our learners a little bit about atypical anorexia.
Yeah, so atypical anorexia, or the technical diagnostic category it falls into, is other specified feeding or eating disorder, so we call that OSFED, is really individuals who have all of the same behaviors as anorexia. So the classical symptoms you think of with restrictive food intake, sometimes engaging in excessive exercise or other behaviors to burn calories, and a hyperfixation on body weight and shape. However, they are not significantly underweight. So technically, to meet criteria for anorexia nervosa, we, in the pediatric world, don't use BMI kind of alone. We use BMI percentile. And so we think of kids that fall below the 10th percentile for BMI as getting the diagnosis of anorexia. And then anyone who falls above the 10th percentile gets this atypical anorexia diagnosis.
So what are how does it present? What are some of the warning signs that we might see?
Yeah, so in some ways it's similar to anorexia. Certainly we're looking for rapid weight loss. We notice kind of that kids become more withdrawn, right? So they're skipping meals, they're avoiding the family, they are engaging in secretive behaviors. So hiding food, throwing away food, exercising in the middle of the night. So some of those traditional behaviors, I think the challenge becomes that when we see these in individuals who actually have often been prescribed weight loss, they're not the red flag they are in our underweight population.
Yeah, I think that's where I've seen it come up is I've had a discussion with a child about their weight and concerns that go along with that, thinking about healthy exercise, healthy nutrition, those types of things. I see them back in 3 months just hoping for a little bit of progress or maybe at least a flattening of the curve. And there's been this rapid weight loss. What as a physician, I'm kind of thinking to myself, oh my gosh, what have I done? So what would your advice be to the people out there?
It's so tricky. I really do feel for pediatricians because of course we want to be monitoring growth overall. And so when someone is kind of skating above the growth curve, we want to provide some of that guidance around food and exercise, all with the best intentions, right? And for some kids who, again, maybe just have the other kind of characteristics that make them more likely to develop an eating disorder, they might follow those recommendations so kind of to a T that they become extreme. I think the thing I always think about with that is how can the parents be the backstop, right? So how can parents really understand that this needs to be more of a gradual process? Because for kids, they think it's working, so they're going to do more and more and more of it, right? But if parents can say, okay, whoa, slow down, my kid has changed overnight, that could be a different conversation.
Okay, so I have a kid in front of me in my office who's struggling with their weight, a little bit overweight. Are there any warning signs for me in that moment that I need to proceed gently or carefully in the things I say so that they don't go sort of in the opposite direction and become sort of a person with atypical anorexia?
So I think something I always wish we asked kids a bit more about is just their dieting behaviors. So a lot of kids are engaging in some sort of dieting behaviors, especially when we think of teenagers. And so if they've already had this kind of predilection to engage in patterns of restriction, and maybe that hasn't resulted in any weight loss, but they have skipped meals or they've engaged in other behaviors, we know that they kind of have that loading to potentially develop more of an eating disorder. And certainly that also goes along with people who endorse really high body dissatisfaction. But this is an understudied population. We don't have great research on what might be unique about these individuals.
Is this something that has existed for a long time, or is this something that we're seeing more frequently now?
Yeah, I think it has existed and we didn't diagnose it. I think really, again, because they were not falling into that significantly low weight category, these were potentially individuals who were just praised for their weight loss and were the odd few who could maintain that weight loss in a way others who try to lose weight maybe couldn't. And just have kind of restrictive patterns that they were lucky enough didn't land them in the hospital. Because that's the thing I like to highlight too is, right, this becomes something where they can be just as sick, if not sicker, than individuals with anorexia. And I think that's when they're finally caught. But these are often the cases that we don't catch until they're hospitalized.
Yeah, we're going to get there. But before we do, so sometimes these patients will come back to me. It'll be 3 months later, and it's very clear how quickly and rapidly the weight loss has occurred. But is there some sort of rule of thumb, like a weight loss of X over X time is concerning for atypical anorexia?
I don't know that there's an exact rule of thumb. I would say in general, it's weight loss in combination with behavior, right? So rapid weight loss is concerning, but also it's concerning if you're hearing from the parents that the kids really just stopped eating, right? So what is supporting that weight loss? It's hard because we don't even really have those data points. It really will be that phenomenon. I'll look at growth charts when kids get to our clinic where they, have one growth point and then the next one is 50 pounds less. And they didn't have any check-ups in between that.
Yeah. And once we discover this, I guess my next question is, what do we do?
Yeah. So again, I think it's a frank conversation then about, hey, I know we had talked about your weight last time. I'm really noticing a change in your weight. What's contributed to that? Like, how did that happen? And asking parents as well if kids are being more secretive, but really trying to get at what are the behaviors that led to that. And also, especially if they've lost that much weight, like, are they still pushing to lose more? Right. So are they really still exhibiting that drive for thinness, want to just keep losing and losing?
So if you were to follow a patient like this, maybe you see them initially, you have a conversation, you feel like you're in a better place. What's the typical course of these patients? Do they, with some counseling, behavioral intervention, do they stabilize, or do they continue to lose weight, or do they regain weight?
All trajectories.
Yeah.
So I think the goal is to interrupt the weight loss, typically once we've identified these maladaptive behaviors that they're engaging in to lose the weight. So we typically don't want them to continue losing. We want them to stop. Then it becomes a conversation around, did the weight they lost lead to malnutrition? So are they now meeting criteria for malnutrition? And so we actually have to do some weight restoration with them. Or are we talking more weight maintenance, where again, we're just interrupting and trying to get them more in kind of a regular pattern where they can maintain at this lower weight, being aware of kind of psychologically how that sits for them and what type of counseling they're going to need. But typically the treatment's going to be the same, where we're recommending family-based treatment kind of as the first line for adolescents, and then cognitive behavioral therapy when there aren't involved caregivers.
People who have anorexia, we see some physiologic changes. One of them most notably is a low resting heart rate. You can also see something called lanugo on the skin, which is, if you lose your fat layer, you're growing some hair basically to retain some heat. What are there similar signs with someone with atypical anorexia, or are they different?
Yeah, so we would see both of those. Potentially. Certainly the low heart rate. We get a lot of kids, again, who wind up admitted medically for bradycardia, and that's how they land in an eating disorder clinic. We're also seeing some of the orthostasis, those concerns. We'll see the report of just being cold all the time, feeling dizzy, low energy, and then some of the psychological symptoms with kind of increased anxiety or mood symptoms. So very similar to the anorexia presentation, because for their body, for many of these kids, especially ones who end in the hospital, they're malnourished compared to where they kind of were typically growing.
Yeah, it's interesting because, they may be in the normal range. I mean, that's exactly the definition, right? Is I think their BMI has to be
above the 10th percentile is how we think of it in kids, or 18.5 kind of for an adult one. Yeah.
Right. So, you would think to yourself, well, they have reserves. And so why, are they in a catabolic state? And, I think just traditionally we think about anorexia as sort of this emaciated appearance, right? And so I think we have to be careful about these kids that we don't miss them. When I think about sort of, hospital criteria for hospitalization, because a lot of these kids need to be stabilized medically, is it the same or different than what we would think about as would we call the other typical anorexia or classic anorexia, or just anorexia nervosa?
It's just anorexia. I mean, I've certainly heard all of the things, and that's a whole nother conversation. There's a large kind of movement to get rid of the atypical anorexia nomenclature, just because that often can feel pretty shaming to individuals. Like, I failed at my anorexia. And so there's been a push to just remove the BMI percentile from the anorexia criteria. But yeah, I think compared to low weight anorexia is typically what I'll say. So we have low weight and then atypical. I think compared to that, we see that the bradycardia is there. So that would be a criteria for medical hospitalization. Where it becomes more nuanced is traditionally might think of a body weight below the 75th percentile for kind of median being a criteria. But for these individuals, that might not be true, right? And we're thinking more of the comparison to their eventually a target weight, but really kind of where they started as being the weight criteria. So that's more nuanced. But yes, you'd see the low heart rate, the orthostasis, some of the other kind of concerns on labs.
So for some kids, I mean, you see them in the office, they may be going into the hospital acutely and hopefully getting stabilized there. For those kids that don't meet that medical criteria, what are we doing as primary care providers? How do we help the kids in real time?
Yeah. So I think hopefully catching it, right? So catching this concerning pattern, like you said, they come back in 3 months or 6 months and they've had such a significant drop. You then have that conversation about what are the behaviors that contributed to this change. It becomes clear that they're engaging in these patterns of restriction, that they're probably expressing kind of fear of gaining weight, desire to keep losing weight. And then you're talking about therapy. So if you're catching it soon enough, hopefully outpatient therapy, again, kind of the family-based treatment model where caregivers are going to take over planning and preparing and supervising their meals for a period of time. If it's gotten more severe, you might be considering a day program, which is really kind of an intensive dose of treatment to address whatever behaviors are interrupting their ability to gain weight or contributing to weight loss. But ideally, we're catching it and we're getting them into outpatient therapy with the goal of either stabilizing weight or some amount of weight restoration.
So we're very lucky to live in a very resource-rich area. What about, for people who may be delivering care on an island or somewhere a little bit more remote than being close to a tertiary care center?
Yeah, I think the main thing is having the conversation with caregivers. So just like anorexia nervosa, most of these kids do not see this as a problem. If anything, they have been congratulated for it and they're pretty excited about the weight they've lost. And so they are not motivated to change their behaviors. So we're going to involve their caregiver to interrupt these behaviors. We're going to have the caregiver provide adequate meals, make sure they're eating the 3 meals and multiple snacks a day, potentially keeping them out of any exercise for a period of time. And then really working with them on kind of bringing things into the light is always what I call it. We want to just get out any of the secretive behaviors, the secret exercise, the hiding food, throwing away food, and making sure parents are really taking a lead in all of those aspects.
Let's get into the neurobiology a little bit, because I think it can be kind of reinforcing, right? There's circuitry in the brain, kind of reinforcing the behaviors. What are the types of things that you can do to actually change those patterns of thought?
So the most powerful thing is to change the behaviors. So we know that there's a connection between our thoughts, our feelings, and our actions. So just the kind of parents getting in there, not allowing them to restrict anymore, addressing the malnutrition if that's there, because of course, working with a malnourished brain is different too. So addressing the malnutrition, interrupting the behaviors is going to start to change the way that they think about kind of food, exercise in their body. And then the biggest other thing I talk with families about is helping them find things outside of that, right? So when someone has an eating disorder, it becomes all consuming. It is all they think about, right? Mm-hmm. They are counting calories all day. They are thinking about, what do I have to do to be able to eat this piece of bread? I have to burn off this many calories. How can I navigate this upcoming meal with my family? How am I going to move food around the plate so I get away without eating? And so it's finding those other things, right? What are things that they can get excited about that start to push out the eating disorder? So in teens, a lot of social interactions because they will have become withdrawn. So really finding things for them to think about instead is important too.
That's helpful. Let's talk about epidemiology. So two things. One is sort of age distribution. My guess is that it mostly happens in adolescence, but I'm not sure. And then also curious the breakdown between males and females.
Yep. So yes, I would say more so in adolescence. And this is that interesting thing too of is it that we're catching it later? Because I think there's typically a delay in diagnosing atypical anorexia that we don't see with low weight anorexia. So low weight anorexia, I certainly see a number of 10, 11, 12-year-olds. I think the atypical anorexia tends to skew a little bit more older adolescent, which might be because they are not caught right away. They have to lose a really significant amount of weight for it to kind of trigger the type of referral to my clinic. But yeah, so adolescence, certainly persisting into adulthood. And as far as males and females, that breaks down a little bit higher percentage of males than kind of typical anorexia. The reason I think being everything to do with BMI, right? And so how males are falling. But yeah, otherwise very similar to the patterns that we see for anorexia. I do notice more diversity in the patients being diagnosed with atypical anorexia, which is also interesting and I think goes against some of the schemas we have in our brain about what anorexia is.
So we just had an episode on, weight loss drugs, which are new and, they're not super common with kids, but they are being used in kids. What about the interface with those new medications and something like atypical anorexia?
Yeah. So I think, again, it's really getting at, are we fully assessing kind of psychologically what is driving their desire to lose weight, especially if the teen is seeking the weight loss drugs, right? That might be a red flag for me a little bit. But just in general, right? Are they putting a lot of emphasis on their appearance and their body weight, kind of defining who they are? And that might be a red flag for me with doing a weight loss drug. I think another consideration with that, right, is especially with kids, like, are they going to take this forever? And if they don't, are they going to gain back the weight? And then are they going to fall into these cycles of kind of restriction and then gaining weight back and restriction over time and really get stuck kind of in time with this atypical anorexia eating disorder focus?
Yeah, I think it's interesting because there's a real nuance between making your body healthier and maybe perseverating or fixating on how your body looks. One of the things I struggle with as a primary care provider is sometimes adolescent boys, especially trying to make weight for wrestling or maybe football or something like that. They really gravitate toward kind of gym time and muscle mass and those types of things. And I can see often like a rapid weight loss with these kids. It could be girls too, but I see it a lot with boys. And I was wondering if you could comment on that.
Yeah, we'll hear that from our male patients and they'll say that, like, I don't have anorexia, right? That doesn't fit me because I don't want to be really thin. I want to be muscular. Like, I actually want to gain muscle is what they'll say. But in the context of otherwise like really low body fat, lean composition, they'll talk about, I don't count calories, but I look at my macros, or I'm really focused on spending a lot of time in the gym, and absolutely can be just as dangerous. And even though it's not a drive to be thin, it is a drive to have a certain body. And so it would fall in that anorexia or atypical anorexia category.
And so you would treat it like you would any other atypical anorexia presentation?
You would. And it can become really much more complicated, right? Because again, for anyone who's going through a treatment where they're going to have to do some amount of weight restoration, you typically gain fat before you build muscle. And so the distress experienced by these males can be extreme, and families may not really see the benefit in the same way. There's not the same kind of markers of we have to restore menstruation. And so I think a lot of times these kids can kind of drop out of treatment, just feeling like it's not for them.
Yeah, I think there's so much nuance here. One of the things I'm hearing is I think you need to take some time, sit down. What are the motivating factors? How, not using this language, not how fixated are you on this, but, asking questions that may get at that information, I think is really important. If you had to give our listeners like 2 or 3, this is what I want you to remember about atypical anorexia points, what would they be?
I think the main one is that it is as serious, if not more serious, than low weight anorexia. So these individuals can have all of the same medical complications, and often have a greater delay to diagnosis. So that's one thing, is just taking it as seriously as we do low weight anorexia. And I think another is really kind of checking yourself around our own weight biases and kind of the stereotype we have of someone with anorexia. And so just because someone's living in a larger body, continuing to have the same conversations around food and exercise and body satisfaction to catch these eating disorders.
Well, thanks, Kim. This is such an interesting conversation, and I've learned a lot. So thanks for being here.
Yeah, thanks for having me.